We clearly know that time is muscle and how important the first 3 to 4 hours for reperfusion. But the question really is, beyond 12 hours, is there much point in doing any intervention to open up the occluded vessel? Now, we classically define late presenters as those who come beyond 12 hours, but usually not later than 48 hours. And in developed countries with mature STEMI programs, it's less than 15% of patients who have this, while in low and middle income countries, and data from India would suggest that up to 50% of our patients are late presenters, and therefore there's a clear importance in this. Now, if you look at Okay. Now, if you look at the, sorry, I'm okay here. The studies which looked at thrombolytic agents, it's the late and the EMERALD study, thrombolysis showed no benefit when it was used beyond 12 hours. And this is the data from the fibrinolytic trialist group, which looked at 22 trials, and you can clearly see that there is no benefit when you look at thrombolysis beyond 12 hours. And therefore, when we talk about late reperfusion, we are actually talking about PCI, not thrombolytic. And we clearly know that there is a time sensitivity when it comes to thrombolysis versus PCI. You can see the benefits progressively come down with lytics, but they stay about the same with PCI. And when you look at the risks, you can again see that the risks increase with the use of intravenous thrombolytics, which are delayed, and this could include cardiac rupture, while the benefits are there with primary PCI, and the risk increase with delayed PCI is not as much. So if you look at the 2021 ACC-AHA SKY guidelines, you will see that less than 12 hours is a class 1A indication. But they've gone on to say that in patients with STEMI who are stable, presenting between 12 and 24 hours, it is reasonable to do a PCI. So this is a 2A recommendation. And beyond 24 hours, if they're asymptomatic, they say is a class 3 indication, so there's no benefit. And this is the ACC-AHA recommendation. So this is what they would say. Less than 12 hours, PCI feasible, go ahead and do a PCI. Beyond 12 hours, if it's cardiogenic shock, heart failure, if it's ongoing ischemia, or if the symptom onset is within 12 to 24 hours, go ahead with PCI, but beyond that, it's a class 3 indication. But is that the total data? If you look at the BRAVE 2 trial, and this is in patients beyond 12 hours, up to 48 hours, and you look at the 4-year data on mortality reduction, you can see that there is a significant reduction in mortality even up to 48 hours. This is the BRAVE 2 trial. And if you were to look at registry data, and this is from the data that comes from France, if you look at, again, this is registry data of patients presenting between 12 and 48 hours, those with revascularization and those without. And you can see that there is, again, even in registry data, there's a clear mortality reduction up to 48 hours. And this is why if you now look at if you look at, this is a meta-analysis done from China, which looked at 18 studies with close to about 14,677 patients who received late reperfusion, that is reperfusion beyond 12 hours. And if you looked at the meta-analysis, if you look at MACE, if you look at all-cause mortality, recurrent MI, or heart failure, you can see that all of them are significantly reduced even up to 48 hours. And yeah, so if you look at the latest ESC guidelines, you can see they've now moved to say that class 1 indication less than 12 hours, but now they've expanded their time limit from 12 to 48 hours. A routine primary PCI strategy should be considered, and that's a 2A recommendation from the ESC. So they've clearly recognized the data, both registry as well as from trial data, to suggest that there is benefit up to 48 hours. Now, what about beyond 48 hours? And the O trial was the trial that really was instrumental in many of the guidelines saying beyond 12 hours or beyond 24 hours, PCI is of no benefit. But I think you need to understand that the O trial was actually patients from 3 to 28 days. And it excluded patients with Killip class 3 to 4, left main, and triple vessel disease. And there is data today, both from CMR studies and with tissue Doppler studies, to show that there is significant amount of viable tissue even beyond 48 hours. So what would be a reasonable way to tackle these patients? If you have a late presenter, and this I'm talking about beyond 48 hours, if they're symptomatic, say hypotension, heart failure, electrical instability, or ongoing ischemia, I think you should take them still to the cath lab beyond 48 hours. High-risk patients with an EF less than 40%, diabetics, I think do an angiogram. If it's a subtotal occlusion, then there is indication to go ahead and do a revascularization. However, if the vessel is totally occluded, I think one of these two techniques of viability, which can be done fairly rapidly, CMR may not be available in many of our labs, hospitals, but strain imaging is possible in many of our hospitals, and that would clearly show us if there's viable tissue, and if there is significant viable tissue, I think we should still take these patients to the cath lab for revascularization. However, if there's no viability, then I think there's not much point in proceeding with this patient going to the cath lab. I think one of the important things to remember in these late presenters is that many of these patients can present with cardiogenic shock. During the procedure, no flow and slow flow are much more common. Reperfusion injury and myocardial obstruction is more common. And I think these are technical issues that one will encounter during a PCI in these patients. Thank you for your attention.